First of all, we'd like to thank everyone for joining tonight's talk. As some of you may or may not know, Utiva is our company. It is focused on UTI prevention. My name is Derek O. I'm one of the co-founders, and I'd like to thank you all for attending. As you can see, the other member here is Faraz, and I'll let him introduce himself as my co-founder as well.
Thanks, Derek. Hi, everyone. I'm the co-founder, as Derek just mentioned. I want to thank you for taking the time to attend today's talk. We will be doing a series of talks, so there will be a survey at the end of this presentation that we highly encourage you to give us your feedback so we can look forward to organizing many more sessions in the future. Over to you, Derek.
Thanks, Faraz. So just one housekeeping tip. Everyone here is muted just because there are a lot of attendees. All the videos are off. If you have any questions you'd like to ask Dr. Nicol, there is a Q&A box that you can find in the chat. You can use either one and type in your questions there, and we will address them with Dr. Nicol at the end of the talk. Some of you may be aware that we were also doing a raffle for your clinics with a couple prizes. Wanted to let everyone know that we will be doing that live after Dr. Nicol's talk on March 8th. So that will be done after the next talk. So right now, I would like to introduce our speaker, Dr. Curtis Nicol. So Dr. Nicol's clinical expertise and research covers inflammatory, infectious, pain, and other benign diseases of the urinary tract. He is director of the Urological Chronic Pain and Urinary Tract Infection Clinical Research Clinics in the city of Kingston, Canada. Dr. Nicol has over 600 publications, is on the editorial board of 6 urology journals, editor of the AUA Update Series and Microbiome Urologic Infection section for Grand Rounds in Urology. He has been continuously funded by the US NIH and Canadian CRC for over 2 decades. Dr. Nicol has been the recipient of numerous distinguished awards and was the first recipient of the SIU Mustafa El-Hilali Award for contributions to international urology research. Without further ado, here's Dr. Curtis Nicol.
Thank you, Derek. And Faraz, this has been a really honor to be able to present something that I am extremely passionate about, and that's the management of recurrent urinary tract infections in women. But tonight, we're going to go have a somewhat different approach. For decades, of course, we've been looking at antibiotic therapy as the way to eradicate infection globally and urinary tract infections, specifically in women. But what we're going to do is look, is there anything else that we have now or coming in the pipeline that's beyond antibiotics, something we can use now in our clinic to manage recurrent urinary tract infections in women? I just have to figure out how, there we go. So get over the preamble. Any woman who's had more than 2 infections in 6 months or 3 infections in a year can be classified as having recurrent urinary tract infections. Women are going to suffer these more than men. About 50% of women will have UTIs, with 25% of women having recurrent urinary tract infections. This results in 500,000 physician visits per year in Canada and 9 million in the United States due to urinary tract infections. Turns out that it's the most common indication for antibiotic use in women. And antibiotic prophylaxis has become the gold standard for management, either long-term low-dose prophylaxis or post-coital prophylaxis. Now, there is a burden of this therapy. Antibiotics were wonderful inventions. Back in the 40s, a small dose, milligrams of penicillin would cure somebody and bring them back from an infectious death door. But we all know now that we have problems. Antibiotics have associated side effects. Personally for the patient, they cause dysbiosis in the microbiome of the gut, and secondary infections become a problem, particularly because antimicrobial resistance has become a huge emerging global health issue. You know, for Canada, 26% of bacterial infections show resistance. and 14,000 deaths a year in Canada. You could probably multiply that easily by 10 in the United States from UTIs secondary to resistant bacterial infections. The healthcare cost of antibiotic resistance in Canada is over $1 billion. In the United States, it must truly be many billions of dollars. Where are we going to go? Well, certainly the AUA, CUA, and SUFU guidelines published last year on recurrent urinary tract infections in women look at where we're going to go, and that's antibiotic stewardship. We're going to try and reduce inappropriate treatment, decrease broad spectrum antibiotic use, and appropriately tailor to the shortest effective duration. But non-antibiotic alternatives, if you read the guidelines, implementation of novel interventions may represent a future direction for prevention strategies. Let's go straight to a case that we're all familiar with. Any physician, nurse practitioner who deals with young females knows this particular patient. This is a patient who has more than 3 UTIs per year, sometimes even way more than that. And the patient starts believing, probably very rightly, that repeated courses of antibiotics are leading to her GI dysfunction, her vaginal yeast infections. And she's starting to find that antibiotics are causing her to feel unwell. And she wants to explore with you other non-antibiotic strategies to prevent urinary tract infections. So what are the guideline statements are? Well, the guideline statements from last year are that for this woman, we can do what's already been done for her, is prescribe antibiotic prophylaxis. We can offer patient-initiated treatment to motivated patients who take antibiotics without culture once we've established that she does have bona fide culture-proven recurrent urinary tract infections. And while not necessarily mentioned in the guidelines, I tend to use post-coital antibiotics in sexually active women because there are benefits in a reduction of UTIs using these antibiotic approaches. But this patient believes that these repeated courses are leading to these problems, and she wants to explore these other non-antibiotic strategies. So what do we traditionally recommend? Well, we tell our female patients that changes in their hygiene practice, wiping from front to back, changing to cotton underwear, not wearing tight jeans, using pre and post-coital avoidance of hot tubs, tampon use, and douching. Well, the guidelines say, and look, the research states that the case control studies demonstrate that these suggestions we use all the time don't have any significant impact on recurrent UTI risk. And they go on to say that these approaches can reinforce the shame and self-blame that are very common in women who are suffering from this condition. However, there is one evidence-based behavioral modification approach that we can and should use. And that's in women who aren't drinking a lot of water, who consume less than 1.5 liters per day. It has been shown that increasing the daily water intake will reduce UTI recurrence by approximately 50%. This is something that doesn't cost anything. It's probably a healthy approach for the general health of the patient anyways, who is likely not drinking enough fluids. Now, the AUA, CUA, SUFU guidelines have examined other non-antibiotic strategies. The guideline statement with a conditional recommendation, evidence level grade C, is that clinicians may offer cranberry prophylaxis for recurrent urinary tract infections. And the reason it's a conditional recommendation is because the evidence is all over the board from multiple studies. Some studies show that cranberry extracts work wonderfully, while others have shown that there really isn't any effect at all. And it turns out that it is the active ingredient, the proanthocyanidins, or PAX, that makes the difference. This is the ingredient that prevents the adhesion of bacteria to the bladder wall. To be able to obtain sufficient PAX to make a difference, you'd have to drink several liters of cranberry juice a day. And that's actually too much sugar. So it's better to use sort of a cranberry extract that has a definitive amount of PAX per supplement. The other supplements that be offered in the guidelines say that D-mannose, vitamin C, and other vitamin cocktails, probiotics, lack sufficient data. And the reason is good studies have not been done. And unfortunately, every study has used a different preparation. Some of them probably were not up to scratch. Now, as far as probiotics are concerned, the Cochrane database shows that some probiotics seem to work better than others in some patients. Certainly, probiotics that are helpful for the gut may not be what we need for the vagina and the urethra. The probiotic research is something that's ongoing, and I think in our particular clinic, my infection nurse recommends probiotics to contain 2 and up to 4 specific lactobacilli bacteria, and we believe that's helpful for many of the patients. As far as D-mannose is concerned, it's a sort of isomer of mannose and E. coli fimbriae, or type 1 fimbriae, attached to the bladder wall through these pili or fimbriae. D-mannose, this isomer, blocks this. Theoretically, should work very well for E. coli and the other Enterobacteriaceae. Well, the EAU guidelines believe that there is some evidence to consider this in patients with these particular recurrent urinary tract infections with these organisms. Certainly, it's superior to placebo and was effective as 50 milligrams of nitrofurantoin a night in preventing recurrent UTI in this one study. Unfortunately, the study was not large, long, or as well done as we would like to see it. The old medication Hiprex that urologists used in the days when antibiotics were scarce sort of lost its use in clinical urology and medicine. However, the old studies, multiple, retrospective, old, very poorly done studies, have described efficacy in reducing UTI episodes, and there's almost no side effects, and certainly it will not promote antibiotic resistance. Something worth considering, bringing back methanamine. Now, what about if our patient wasn't a young female? What if it was a post-menopausal female with recurrent UTIs? Like this patient, 67-year-old post-menopausal woman, has UTIs since menopause. Prior to menopause, she may not have been having these UTIs. She's been successfully treated with multiple courses of antibiotics, but her UTIs recur in constellations. She's requiring a lot of courses of antibiotics over a year, and including long-term low-dose prophylaxis. She's looking for recommendations other than antibiotics to prevent these UTIs. And the evidence-based recommendation that we would make, and it's a guideline statement with grade B evidence level and a moderate recommendation, that in peri and post-menopausal women with recurrent UTIs, we should consider recommending vaginal estrogen therapy. We worry that vaginal estrogen therapy may have problems in patients with cancer, particularly breast cancer, but this doesn't appear to be the case. Although I'm still somewhat reluctant to prescribe it unless I have full consent of the patient in women who are recovering from breast cancer. It's the vaginal estrogen and not the oral that we recommend. And there really has not been any study that shows one application or one type of vaginal estrogen preparation is better than another. And in older women, postmenopausal, I also recommend, with less evidence in this age group, probiotics, D-mannose, and cranberry. Now, recent research that I have been privy to and that we're going to continue to look at with more research is the fact that we might not be doing our patients a favor by prescribing D-mannose and cranberry at the same time, or at least not being taken at the same time, as one may negate the efficacy of the other. This is something that I hope within a year or so we'll have a little bit better evidence of how we should be dosing these alternate therapies. Now, what's the future for recurrent urinary tract infection? Personally, I believe it's vaccines. In this COVID-19 era, that's all we hear is vaccines. But in this particular case, it's something we've been working on for a decade. There is one vaccine that I've been involved with, Urovaxin, which is being used in Europe with some success. Although the studies, the good studies, the randomized placebo-controlled studies haven't shown that much efficacy, except older studies would seem to be that it's working. The new kid on the block is Urimune. It's not available in North America, but I'll show you what's going to happen soon over the next year or so. And you'll have your eyes to the news as this becomes available in North America. Certainly, the guidelines state that the implementation of these type of novel technologies, such as vaccines, may represent a future direction for prevention strategies. Now, we recently, only months ago, looked at this particular sublingual vaccination. Is it going to be a viable option for the prevention of recurrent urinary tract infection in Canada? We did this systematic review for Health Canada, and this vaccine now is on fast track for approval in Canada and will soon be going to the FDA with this evidence. 2 studies, antibiotic comparator groups, when you lump them together, 519 who take 3 months of sublingual spray vaccine, 2 puffs a day for 3 months, versus 499 who are on antibiotic prophylaxis for anywhere from 3 to 6 months. The difference was astounding. UTI free rate for a woman with recurrent urinary tract infection is an objective, fantastic result, going from more than 3 and sometimes way more than 3 in the course of a year to being UTI free. If you look at prophylactic antibiotics, this showed what other studies have shown. Prophylactic antibiotics work while patients are taking them, but shortly thereafter, they revert to their recurrent urinary tract infection status, where the opposite occurs with this particular vaccine. If we look at the 3 observational studies without any comparative, the UTI free rates range from 33 to 90% over anywhere from 9 to 24 months in the real world. And this appears to be safe. And the reason it's safe, it's not an injectable. It's a mucosal vaccine sprayed under the tongue, which confers an innate and direct immunity against these bacteria and related bacteria in the vaginal, urethra, and bladder mucosa. All these studies, in 1,407 women, only 2 stopped the vaccine because they thought it might be causing a problem. In post-marketing experience in women who receive it in Europe, Australia, Dominican Republic, Mexico, Australia, in special access programs, it's been given to over 20,000 patients, and the number of serious or even non-serious reactions are very, very small. There are no major safety concerns in this medication. And what's happening in the pipeline from North America? Well, we initiated a Canadian early experience, clinical experience study mandated and approved by Health Canada. They wanted us to have North American experience with this vaccine before it was approved. The primary outcome was no UTI in the 12 months following initiation of the vaccine. We have finished the analysis of the pre-COVID-19 cohort. We had a 6-month mandated cessation of enrollment. We're back enrolling for this particular trial again. And the results of this trial will be presented at urology meetings in Canada and the United States in the late spring and summer. The European phase 3 randomized control study is the definitive study. I helped design the analysis plan, the interpretation, and writing up this. The study is completed. The results are embargoed until we present it at international meetings. But I can tell you right now, this pivotal trial has shown that we have a game changer in the management of recurrent urinary tract infections. And it's going to be so much fun over the next 6 months to present these particular clinical trials. Now, that's to prevent them. Is there anything we can do for patients who suffer an acute urinary tract infection? She's got recurrent urinary tract infections, getting tired of antibiotics. Is there any other options? Well, the antibiotic options, we know, first-line therapy using a shorter duration of antibiotics is reasonable. Using the nitrofurantoin, trimethoprim sulfamethoxazole, or trimethoprim alone, or the old kid, which is now the new kid on the block, fosfomycin. but not fluoroquinolones. We now know that fluoroquinolones should not be used for simple uncomplicated UTI unless nothing else is available, because of the problem not only with tendon injury and rupture, but we know more serious mental side effects, including suicidal tendencies, neuropathy, which are chronic and don't resolve over time, and more recently, significant risk of aortic dissection with the use of fluoroquinolones. So in urology, we're now recommending no use of fluoroquinolones, not even for transrectal prostate biopsy. Now, here's the interesting thing. You're tired of antibiotics. What do the guidelines say? Well, the guidelines and the evidence, and these are from little older studies, but some have been done as recently as a decade ago. The UTI is typically self-limited and rarely progresses to more severe disease. In fact, we had UTIs and recurrent UTIs before antibiotics were introduced in the 1940s. And if it was a simple, uncomplicated UTI, patients did not die. Only if it was a complicated UTI. The incidence of pyelonephritis and sepsis is low, and it's not substantially different in individuals who receive antibiotics versus those who decide not to take antibiotics and just have supportive care. And that's what I'm going to be talking about. Now, what's most interesting is there are multiple randomized placebo-controlled trials demonstrated little benefit to antibiotics for UTI beyond modestly faster symptomatic improvement. Well, unfortunately, a lot of our patients want that, but many would forego that if they could avoid antibiotics. So there are 5 randomized placebo-controlled trials. And what did they show? Well, certainly we could predict that antibiotics would be superior in terms of clinical success, cure, and bacterial eradication compared to placebo at 3 and 7 days. But at 10 and 14 days, there wasn't much difference in any of these parameters. No significant difference in urosepsis or pyelonephritis, except the latest trial did show a slightly increased incidence of pyelonephritis, something that I warn the patients who have a UTI who decide not to go the antibiotic route, that if they have fever or back pain, that they have to seek help and antibiotic therapy. What they did note that the antibiotics were associated with a much higher risk of side effects than placebo. The message is that many patients successfully and safely can respond to placebo. So if we decide we're going to go the non-antibiotic option for the treatment of acute uncomplicated UTIs, what do we use? Ofenazole-pyridine or pyridium, NSAIDs, both of them. We know the pyridium story. It's been the urologist's friend since it was introduced early last century. And we know that it symptomatically helps patients while Mother Nature affects the cure. The NSAIDs, however, help patients at the time by reducing the inflammation, the pain, while again, Mother Nature affects the cures. And the studies have shown, randomized placebo-controlled studies published only several years ago, show the effectiveness of NSAIDs compared to antibiotics. I use urine alkalization. The Cochrane database study or database looked at all the studies. They were all old, poorly done, no comparisons, all different types of alkalization, and they could not come up with a conclusion. Well, my conclusion is that alkalization in my patients helps some patients some of the time. And certainly the less expensive option of a tablespoon of sodium bicarbonate in water makes it worthwhile trying that. I and others have used Hiprex or methanamine. However, the Cochrane database and the guidelines say it really has little utility in UTI treatment. Where I see it helping is a patient likes to take something that's not an antibiotic that they believe is helping them. Well, what about way beyond guidelines? Herbal therapies. Patients, as you know, in this era, would like to have some from a herbal, non-pharmaceutical, natural product. And this also goes for women who have recurrent UTIs. And if you look at the evidence presented by the National Center for Homeopathy, they do have a number of herbal therapies that they believe is helpful. Most of them are based on theoretical in vitro data with very few studies. We have 3 major herbals that if patients really want them, the golden seal root, uva ursa, and echinacea, that we recommend to our patients. We don't believe it hurts anything but their pocketbooks. Now, diet. diet is a big thing for health right now, particularly to this COVID time, and everybody's looking at plant-based diets and various ways to improve their diet and their health. Well, we know, based on in vitro studies and historic studies, that some foods do actually contain natural antibiotics. So the evidence is even more poor because it's really anecdotal internet reports where we find this evidence. But we do have a number of dietary supplements or dietary foods that patients are so inclined, we suggest that they try and add to their diet to see if it helps prevent recurrent UTIs. So you can see where I'm going with this. The question I pose tonight, based on the presentation I gave, is can we now start to at least consider managing simple, uncomplicated UTI like we do the common flu? And like hopefully in a year or two, we'll be managing COVID-19 with supportive care, supplements, vaccines, and no antibiotics. So that's the end. I would like to end with some presentation pearls just to make sure I'm not misleading anybody here, because antibiotics in 2021 remain our primary intervention for urinary tract infections. But antibiotic stewardship must be our priority. Based on the fact that females with simple cystitis survive before antibiotics, and placebos work almost as well as antibiotics, and NSAIDs almost again as well as antibiotics, we now are developing evidence-based strategies for preventing recurrent UTIs in females without antibiotics. Now, this would be the cranberry, the probiotics, the D-mannose, and eventually, I hope, in a very short time, is vaccines. And we just discussed the strategies to manage acute recurrent UTIs in females without antibiotics as well. But unfortunately, the case is that women, as we all do, would like a quick fix. And for most women with symptomatic recurrent UTIs that we cannot prevent using these alternative therapies and management strategies will require episodic, prescriptive, self-start, post-coital, or prophylactic antibiotic management. Antibiotics are here to stay for now, but for a simple, uncomplicated UTI, we do have alternatives. Thank you very much. And I hope that you learned something from this, but I certainly enjoy talking about it, as you can probably tell. And we're going to work out some questions. Are we now, Derek and Faraz?
Correct. Thank you, Dr. Nickel, for the talk. We do have quite a few questions here, and I'll jump right into it. So we have a question from Michelle. Do you see a difference between best treatment for post-coital UTIs versus other recurrent UTIs in premenopausal women?
I think for premenopausal women who are sexually active, post-coital antibiotics is a very good stewardship approach to antimicrobial therapy. Studies have shown that it cuts down the UTI rate by as much as 75%. And I think it's what I tend to do for most of my patients after a short period of prophylactic antibiotics to sort of stop the constellation of recurrent infections. And then I put them on post-coital or self-treatment protocols. You only have to use a small dose. And remember that when we talk about sexually active women, the UTI, she does not have to tell you that the UTI occurred the next day, because the way our microbiome gets disrupted with coitus intercourse is it could take up to 5 to even 7 days after sexual intercourse before the microbiome turns pathogenic and a urinary tract infection actually occurs. But by giving one dose of antibiotics, it swiftly goes through the system, the best probably being nitrofurantoin or macrodantin, will sort of get rid of that onslaught of bacteria that are introduced into the urethra and bladder during sexual intercourse.
Thank you, Dr. Nickel. Next question is from Brenda. What is the effect of Uroimmune on E. coli in the colon?
We absolutely do not know. We're running a study right now in Kingston at my institution where we're looking at the urinary microbiome of patients to see the influence on a patient with recurrent urinary tract infection, which probably has a dysbiotic or microbiome, or one with very poor ecology, and we're hoping we'll be able to see it normalize. As far as the gut is concerned, it could still be impacted from the systemic innate immune stimulation that we're getting. But as far as the Urimune, or MV140 is what we call it, getting into the gut itself, it doesn't happen. It's sprayed under the tongue where the activity is activated and stimulated. Then after under the tongue for a short period of time, the patient swallows it, and the entire thing disintegrates in the gastric acid of the stomach and doesn't get into the small bowel. So we don't get any local type of impact. All the impact we would get would be on the bowel mucosa. And if you remember, we do not want E. coli adhering to our bowel mucosa, and all the bowel defenses are to stop that. We want the E. coli to be within the gut itself, doing all the important things that the microbiome does in the gut. So at the present time, we now have many patients who've been on this in clinical trials and special access programs. We've not seen any gut or GI consequences with the use of this particular vaccine. Very good question.
Thank you for that one. We have a question from Adebola. Can you please kindly comment on management of recurrent UTIs in neurogenic bladders?
Right. Are you ready for another 30-minute? Actually, we have to take a little bit longer time for that particular talk, because neurogenic UTIs with neurogenic bladder are complicated UTIs. They can be recurrent, or they can be relapsing, or they can be chronic. Now, what we do now is many of the same things that we do for simple uncomplicated. Some of the supplements that I've mentioned can be helpful. I do use D-mannose and high concentration of cranberry extract, and I find that to be beneficial, as long as we're able to treat the patient with supplements with an empty bladder, usually with self-intermittent catheterization. The antibiotics are used sparingly as much as possible, because a microbiome does develop in neurogenic bladders, as in all bladders, and antibiotics are going to disrupt that and make it more pathogenic. If we fail everything, I'm resorted now to using intravesical therapy, injecting antibiotics directly into the bladder. I'm sorry, I'm not covering it all, but that itself is a complete lecture, is the management of complicated UTI. Good question.
Thanks, Dr. Nickel. We're going to, we have a question on vitamin C. Is there anything on the use of vitamin C in prevention? The guidelines committee, the AUA, CUA, SUFU guidelines committee, reviewed vitamin C and looked at all the data in the literature, and they were not able to come up with a definitive answer, not even a wishy-washy answer. And at this point, they do not recommend vitamin C as a treatment for patients with recurrent UTIs. I personally believed 20 years ago that acidifying the urine for some types of recurrent UTIs would be a benefit, but we've never been able to show that. I do know that patients who take vitamin C and have a UTI are more symptomatic than those who aren't taking high-dose vitamin C, probably because of the acidity. Okay. We have quite a few good questions coming up here, Dr. Nichols. So here's another one. Where do you see the guidelines for NSAID use? And would this not just hide the infection through pain control?
No, the NSAIDs story is very interesting, because many patients, my patients who are avoiding antibiotics, use NSAIDs on my recommendation. And it's based on evidence, but not solid evidence. It does point that NSAIDs help patients with inflammation and pain, And we already know that patients on placebo will get resolution of their UTIs anyways. And that's the reason I use it for symptomatic. They don't treat anything but the symptoms, like I said, while Mother Nature affects the cure. So they will never be a high recommendation. We also have to realize that NSAIDs have consequences as well. If patients become too reliant on NSAIDs, we will see anti-inflammatory side effects that may be more deleterious than what they saw with antibiotics.
Okay. Here's one on embedded bacteria. What are your thoughts on embedded bacteria in the bladder of the biofilm that gets shaken out during SI, I believe sexual intercourse, as a cause of recurrent UTIs?
Well, that's, I'm glad somebody asked that. That's how I made my career. I did my fellowship in industrial microbiology and had the first 17 papers published in the literature looking at the microbial biofilm in various diseases, including urinary tract infections. And I spent 20 years, millions of dollars looking for that elusive microbial biofilm in women with recurrent UTIs. We found it in some species of rats where we gave them chronic UTIs. Very rarely find it in humans. And when we try and find it again, can't find it. I thought we would be able to find it in biopsies and exfoliated cells, just not able to find it. So unfortunately, one of the greatest theories that I ever had, that embedded bacteria or bacterial biofilms, as it were, a cause of recurrent cystitis in women, has fallen beside the wayside. I do note that other people have taken up the torch, but haven't spent the years in the lab and clinical research like I have. That being said, for complicated UTIs and chronic UTIs and relapsing UTIs in complicated patients, biofilms are the key. Understanding how bacteria survive within the bladder, on urinary stones, on prostheses, in scar tissue. That is the key to understanding the rationale and the difficulties in treating complicated, particularly complicated chronic and relapsing UTIs. So for those patients, the biofilm and embedded microcolonies, or I used to call them bacterial factories within the urinary tract, those are the ones that are doing it. For women that have recurrent UTIs, the patients that have chronic bladder pain and believe they have UTIs, probably not. It's probably not a real thing in my mind. But being a scientist, I'm always willing to be proven wrong.
Sorry, I was muted. So here's another question. Can estrogen topical cream on the urethra and vagina during low estrogen periods in non-menopausal women, day 14 to 28 in cycle, something to be studied? Yes, that's the question.
Wow. Somebody is very insightful. What an interesting idea. And I do not know the answer. Myself, I believe it's unlikely, because what the estrogen therapy does in postmenopausal women is take thinned atrophic mucosa with a very, very thin mucosal glycosaminoglycan mucin layer on it and improve the health of that mucosa so it looks close, not quite, but close to what a premenopausal woman vaginal and introital mucosa would look like. So I don't see a postmenopausal looking vaginal mucosa in premenopausal women, So my feeling is that it probably would not make a substantial difference. But what an interesting thought, something I've been dealing with this now for like 35 years, and I never, ever thought of that particular approach.
Okay. Another question here. I often see women suffering from recurrent UTI also suffering recurrent yeast infection. Is there any relationship between them?
Oh, yes. It's a direct relationship as a consequence of the therapy for their recurrent urinary tract infections. What happens is that antibiotics, almost everyone except one, severely impacts the microbiome of the vagina, introital area, periurethral area by wiping out the lactobacilli, the corynebacterium, even the staph and the non-hemolytic strep, and those ones that sometimes we worry about. It wipes them all out. And an opportunistic organism that is kind of sitting there all the time takes over the landscape, and that's Candida or the other yeast, and we end up with a yeast infection. It is such a common problem for women with recurrent urinary tract infections being treated with antimicrobial therapy, either prophylaxis or episodic. Now, the only antibiotic that doesn't cause disruption in the microbiome or the microbiota of the vagina is nitrofurantoin or macrobid. And that's because it is absorbed very quickly. You take the pill and it's pretty well absorbed in the stomach and high up in the gut, so that it doesn't even get and change the bowel microbiome. It goes one run through the body and then excreted in high concentrations in the urine and then voided out. So what it does is it gives you a great urinary flush of antibiotics that doesn't impact the bacteria, the good bacterial populations of the lower bowel and the vagina.
Okay. Do you believe that Utiva or cranberry for 3 days would be as effective as post-coital antibiotics for 1 day?
My answer is I have no idea. I've never seen any evidence, and I've never used it that way. I don't know if I have any patients that have used it that way, so I don't even have any anecdotal experience. The cranberry extract, it doesn't work like antibiotics. You have to look at a lot of women in studies to be able to show a significant difference. There's a number needed to treat to be able to see efficacy in a population. So while I have no doubt that it works when you take it continuously, I doubt, but of course I don't know, that it would work as episodic prophylaxis. But again, I would be so willing to be proven wrong, either by a single patient's experience who finds it works, or a properly done study. In fact, a lot of what I've learned from treating recurrent urinary tract infections over the last 30 years has been anecdotal stories from my patients of what's worked for them. But what's always unfortunate with this is what's worked for the woman that was just in and told me that wonderful story doesn't work for the next patient I have that almost has the same problem. So that's why we've got to go as best we can with the best evidence that's available from clinical studies and trials and real world studies as well.
Thanks, Dr. Nickel. Here's a question. Based on your earlier comment, can you further elaborate on the interaction between D-mannose and PAX?
I would like to, and what I can say is that I'm privy to some very early data. And when we looked at that, because I have always sort of prescribed multimodal therapy using, in many patients, going all in with D-mannose, cranberry, and probiotics, figuring that if one helps, two might help more. But a small study that was actually funded by Utiva, which we're going to expand upon, looks like the addition of D-mannose to cranberry extract reduces the anti-adhesion qualities of both. So the question is, should we asynchronously prescribe it? In other words, one in the morning and one at night. The one at night, of course, probably best one would be the cranberry, and the one in the morning would be D-mannose, and likely not put the two together. And until I see more data, I'm certainly not going to recommend to any of my patients that they use a combination product at this time.
Here's another question on the natural side. What are your thoughts on aloe vera supplements for UTI management? I have heard it is in use along with the alkalinization types of management. Sorry.
Yes, I've had patients tell me it works as well. Perhaps it should be on my list. It's not, because it's not one of the top ones that I know of good evidence. That being said, you know, there's a lot of anecdotal experience with a lot of phytotherapies. I mean, think of before we had antibiotics, when you know, the early North Americans, before we even arrived, they were managing UTIs with cranberries from the cranberry bogs. In fact, my grandmother had a recipe for UTIs, which was mashed up cranberries and honey. What did she know that I don't know? So a lot of these things, you know, do have remote traditional evidence that's just hard to tease out the way we do now with evidence-based medicine. So as long as it doesn't cause any harm and the patient is experimented and feels it helps, I will support that.
Just to let you know, we'll cut it off in about 7 minutes. Dr. Nicol, the questions keep coming in, but we'll go for another 7 minutes. So if anyone else, any of the other questions, you can still continue to send them. Okay, here's the next one. Are you doing PCR testing on urine samples in recurrent UTI women? In a study of women who tested negative on CNS, but were symptomatic, and the other group non-symptomatic with negative CNS, all the symptomatic women showed genetic material of the bacteria. This could have been one of your studies?
No, it's our studies are coming out. Our studies are going to be the largest ever. So we've just submitted abstracts to major urology meetings. You probably saw it the first. I'm a consultant to Microgen DX, which is the largest next generation sequencing outfit in North America, analyzing urine samples for possible bacteria. I've been helping them try and interpret the results of the thousands of patients who send in their urinalyses, and it's been very difficult. So they funded a very large study, and we just completed it and analyzed it, and I just submitted it actually this morning, looking at the normal urinary microbiome in healthy individuals. We then looked at all the healthy individuals in a large NIH study, hundreds, and we ran them through NGS and looked at them, and we're comparing these two major studies which used independent methodology to look for genetic material, as you say, within the bladder. Then what we're doing is we're looking at literally thousands of symptomatic patients who are in the database. The database that I have in my office at home contains the microbiome data from 80,000 patients, none of whom I know who they are. All I know is the age and the diagnosis. And we're comparing men with symptoms to women with symptoms, women to symptoms, without women with symptoms. We're also looking at patients with a condition called interstitial cystitis, which some believe may be related to a dysbiotic or poor ecology in the bladder. And finally, we just had a huge grant to look at patients with symptoms of UTI and negative cultures, and we're going to do an outcome study to see if we treat the bacteria that are identified in the next generation sequencing or NGS analyses, whether they benefit from directed NGS therapy. So this is an exciting time. The way I've been treating UTIs over the last 30 years has been based on a culture technique that was discovered at the turn of the last century, 125 years ago. And we're using exactly the same technique in our laboratories. And we're probably making huge mistakes in many patients in not identifying what's going on in the bladder. So that question, I did not set that question up, but that for me is a whole another lecture at another time.
Okay. Can you use fosfomycin for post-coital UTI prophylaxis, or is nitrofurantoin better? Do you use one dose only?
Yes. So I tend to use nitrofurantoin for post-coital dosing because over the course of time, it's very little dosing. You can use 100 milligrams of nitrofurantoin or macrodantin. Macrobid is probably overuse. You're probably, a single macrobid tablet is probably more than you need. This the problem is not everybody can tolerate nitrofurantoin or macrodantin. However, most patients actually can tolerate a single dose. It's only after they've been taking it several days that they get a GI upset. As far as fosfomycin is concerned, it's a pretty wide spectrum bacteria, and it's going to play havoc with your bowel microbiome and your vaginal microbiome. And at this point, even though it's an older antibiotic that we forgot about, I tend to like to reserve it for actual UTIs rather than prophylaxis. That being said, we have just changed, as many others, using fosfomycin instead of ciprofloxacin for our transrectal ultrasound biopsy prophylaxis. So the story isn't over yet with fosfomycin, but truthfully, I've not used it for post-coital antibiotic therapy. I reserve it for when we actually have a UTI that requires therapy.
Okay, thanks, Dr. Nickel. We'll have two last questions here. Do you think oral contraceptive pills contribute to recurrent UTIs?
Well, oral contraceptives, recurrent UTIs, and antibiotics are another story in itself. The effect of prophylactic antibiotics for recurrent UTIs in sexually active women on birth control pills and the failure of birth control pills because of the long-term antimicrobial therapy is a whole story, another lecture. Do birth control pills on themselves cause recurrent UTIs? Unlikely. The population data that I've seen that shows that young women on birth control have more UTIs is probably, I'm trying to say this safely without getting into trouble, is probably reflective of the general sense that young women on birth control may be more sexually active than young women without. And I know that I say that without really having the evidence behind it, but that's the way I interpret that data. And that's about all I can really say in a couple minutes about birth control antibiotics and recurrent UTIs.
Okay. Our last question for the evening here. Is there any evidence for what you have talked about today in the pregnant population? What about recurrent asymptomatic infections in pregnancy?
Well, right now, because bacteriuria in pregnancy is a red flag. Those patients are not categorized as uncomplicated UTIs, and UTIs and even asymptomatic bacteriuria in pregnancy should be treated with a short course of antibiotic as possible that's safe for the fetus in that particular trimester. As far as the use of supplements, there is no evidence in the pregnant population that they're of any benefit. There's no evidence to show they do no harm, but there's potential harm in not fully treating a potential UTI or bacteriuria in a pregnant woman. So for the most part, no, I do not use these particular strategies in pregnant women with recurrent UTIs and or asymptomatic bacteriuria.
All right. Well, Dr. Nickel, we truly appreciate your time for doing the talk. There was a lot of Q&A, and I hope everyone found that informative. Before everyone leaves, just to let you know, there will be another talk on March 8th. So there will be opportunity to answer more questions. If anybody wants to reattend or forward the invitation on to colleagues, you're always welcome to do that. Once again, thank you everyone for attending. Faraz, do you want to say anything?
No, I just want to thank everyone, and we'll have a follow-up email that goes right after this session to remind you on the survey, and if you need any follow-up information on Utiva or anything else we can support. Thank you.
Thank you, Dr. Nickel.
Thank you, Dr. Nickel.
Okay, bye now. And
Bye-bye.
thanks for hanging in there, everybody.
Yes. Glad everyone stayed. Have a good night.